then the C5,
Where is
C6
it?
is involved. C5, C6,
Here,
is it 5, 6, 7, 8 and T1?
T1,
5, 6, 7,
Small muscles are
8
supplied by
and
C8
T1.
and T1.
So involvement of these ones are presence of this is 6, 7 and 8. And T1 is this.
reflexes, upper limb.
The upper reflexes, upper limb, biceps are normal in the both limbs. Triceps are normal. Supinator cannot elicitate the patient.
Both the side.
Why?
Not elicitate.
Why? What is the root value of supinator and what is the root value of biceps?
5, 6 for biceps.
And supinator?
Supinator.
If
biceps can be elicited, you can.
supinator should be elicited. Are any of these brisk? Is biceps or triceps brisk?
The biceps is slightly.
What about triceps?
Triceps appears to be normal.
It is normal.
Appears to be.
Lower limb,
Lower limb there is no reflexes are elicited.
Power?
deep tendon reflexes are
No.
Power 0/5
Power
completely.
Zero. Completely.
superficial
Partners are
reflex.
not elicited. No response.
Superficial.
Partner is not elicitable.
The abdominal reflex there is no response and no response for the domestic reflex.
Sensory vision.
In the sensory examination, is all
Partner
the
difference.
Lower limb, plantar.
For how many days is it like that?
16 days.
After 16 days, do you expect these marks and all to be working efficiently?
What happened to the sensory vision?
all the sensation below the nipples are lost.
Completely lost.
Completely lost. Temperature, pain, and
Touch.
vibration, touch,
Till what
all are.
level?
Below the level of? Now,
Below the
doctor,
level
now
of-
you are giving examination findings. You should give it in dermato. It is, or it's not history. So now you should say which level. Which level?
It's around D4 to D5.
Why there is weakness of small muscles of hand then?
Exactly, that is.
अगर D4 पे lesion है तो फिर why there is weakness? That means there has to be lesion upward.
Sensory level is a D4.
I
Look for if you have to make a
In upper limb there is no sensory loss.
Upper limb there is no
No
sensory.
sensory.
And in the spinal examination, there is a slight tenderness in the T3, T4 level. Slight
There
tenderness.
is a local tenderness at the
Just mild.
posterior column? Posterior column is gone.
No
lower
vibration.
limb.
No vibration sensor. Till what level of spinous process are you able to elicit vibration? Out of all three, sensory, posterior column and motor system, which is the most accurate to localize level of lesion in cord lesions? Did you get the question? Out of sensory, motor and posterior column, if you want to localize the level of lesion within the cord, which is most accurate among the three?
Sensory.
No, it is
Posterior column.
posterior column.
The important thing is that whenever you are localizing in upper limb, the reflexes are important for making a diagnosis, making a diagnosis. In trunk and leg, the sensory is more important. The posterior column is a part of sensory involvement only. Band-like sensation, you do tuning fork test. And
At
tuning
each
fork
spinal
test is a
process.
very sensitive test to find the local level.
So what's the final?
One more thing you should do in this patient you have not done. Yeah, fundus. Why? Why? Why fundus? Just because we have to do fundus, so
To rule out multiple sclerosis.
if you have thought of ATM as a diagnosis, acute transverse condylitis, you should look at fundus. So now please give me your final diagnosis.
And with the level.
Yes, I mean final diagnosis.
I need to know whether cervical cord is involved or not, or it is just everything is at a thoracic level only.
Young male with the paraplegia
वो तो quadriparesis बोल रहा था यार, paraplegia.
Quadriparesis with the ball
No,
and
has he got quadriparesis or he's got paraplegia?
paraplegia. ma'am.
He's got paraplegia.
जो
Okay.
एग्जामिनेशन में मिला वो
A 23-year-old male from paraplegia with the ball and bladder involvement.
Acute onset
Acute onset
paraplegia.
paraplegia with the ball and bladder involvement. With the sensory level at D10.
At D10.
Oh, T4. Sorry.
With bladder ball involvement, you said. And you see compressive, non-compressive.
अभी तो full
Full diagnosis
diagnosis.
थोड़ी हुआ ये तो।
ये तो आपने reach है ना, compressive,
ये तो physical diagnosis
non-compressive.
दिया आपने।
Compressive है तो कहाँ है level of compression? Extradural, intradural, intramedullary, extramedullary. If it is non-compressive, what is the level? What is the etiology? This is has to be your full diagnosis in cord cases. You have reached only one part of it. Go further.
It's most likely non-compressive.
Non-compressive
And then etiology.
Etiology.
You say non-compressive level probably D4, etiology probably viral infection or some infection or traumatic.
Or transient.
Cause is viral infection.
So the next question obviously would come in this would be, what about the involvement of the upper extremities? That is the question in everyone's mind.
Can you explain this again in this case only?
Anyone here?
Regarding
Upper limb involvement. He has
Upper
done
limb.
it.
We got a definite sign at D4. But when you look at, he's got some features, some weakness in the upper.
Can anybody explain that?
Maybe cellulitis.
No, cellulitis cannot
It's
explain
bilateral.
weakness.
Bilateral.
explain weakness of this?
it's bilateral.
Cellulitis is only unilateral. Left side.
Motorist always choose multiplier higher than the sensory because
No, it's opposite way. Sensory is higher above than the motor. Not motor is higher. Sensory, because sensory when it ascends and decussate after two levels. So sensory is always higher than the motor. So it has to be opposite way. अगर ये D4 पे sensory बोल रहा है तो motor तो D6 पे होना चाहिए. लेकिन हमें motor मिल रहा है C5 C6 पे. Can we explain that?
Cervical spondylosis.
One thing, he can have cervical injury also.
Anything else?
Multiple level of involvement.
What is multiple level then? What else? Arachnoiditis is a cause of multiple levels.
Inflammation of the body.
Metastasis and all that.
Adjacent inflammation of the body.
That should be
Cause
patchy.
of multiple level or patchy level?
It's not
Patchy
cause
lesion.
a dense kind of thing. So what else? What else can happen? That has led to this kind of.
Associated cervical spondylosis is one.
too young to have associated spondylosis.
Sometimes it happens is that whenever is the cord involvement, the edema is usually 2 to 3 segments higher or more. So you can have sensory level at say D4, but due to edema or this involvement of the upper levels. Similarly, due to if there is vascular compromise, there can be infarction of the upper level. Though the lesion is at say T4, but due to decrease in the blood supply, there is small infarction at the upper level.
That's why the importance comes out of the watershed area. This is where you have the T3, T2, those is the side between T2 and the cervical, you have the watershed area. And the cord edema sometimes extends better. So if you now with the availability of the MR imaging, you will pick up a lot of these patients that they have extensive
Do we have the MR of this
signal
patient?
injury.
then why only the motor system is involved?
Yes.
That is because of, you tell me why. Why? We are not talking of a complete transverse myelite picture at that level.
It is
And
patchy.
that's why it is only small segment getting involved.
I
Not,
said sensory level is more,
that is already there. Just 1 or 2 segments. It cannot go up to 5 segments. T4 and C5 is 5 or 5. So that is explained only on the basis of these. And you would see quite a few number of patients, especially of those with acute transverse myelitis, would have this kind of presentation, especially when they have a transverse myelitis level at D4, D5, D6. One which you have with T10, D9, 10,
Very clear.
generally you would not have any
Upper
upper
limb.
limb. These are the 2 explanations. Otherwise you do not have. Of course, you can talk of anything else separately here as spondylitic lesion or something, that is different.
If it is too young, there is no history.
Otherwise, no
I
expression
wouldn't
coming.
even
Only the
consider.
cord edema
Yes,
and this is the
extending up to
fracture.
the.
This is the reason which is explained.
Plus he's
But-
lying in bed and maybe it's that he's not able to resist. The muscles are not enough. He's not using the limbs.
What is the point of intramedullary compressive lesion in this case?
What is it?
You say it's a non-compressive. I say it's a
Intramedullary compression.
Intramedullary compression.
Intradural intramedullary compression.
How is it? How can you differentiate it from your non-compressive myelopathy lesions?
one it's intramedullary compressive versus you said it's a non-compressive. I said it's a
Intramedullary
compressive.
Compressive are generally slight progression is not.
The presentation is same in both cases. You have to do one test which you haven't done to differentiate between two. That's it. That is sacral
Cerebral
sparing.
sparing.
Sacral space.
Sacral sparing is seen in intramedullary compressive lesion, while it is not seen in
See, even intramedullary compressive lesions can present with early bladder involvement.
because the presentation is same in both the cases.
They can present to you with, but again, dissociative anesthesia, and of course, partly you are right also that such a sudden dramatic
Picture will not be.
at time would never occur with intramedullary compression. That is one, but the important component you should never forget is about sacral
Sacral
sparing.
The cord infarction can occur and that can cause again
Yeah,
catastrophic.
yes.
Can cause, expansion can cause. Any question?
Yes.
You said that sensory examination, when we have decided the level, posterior column signs are better. Like when we test for vibration, we generally test vibration of bony points. So it's either the lower costal, lower ribs or anterior-superior iliac spine.
You have
You are
vertebral
supposed to
spines.
test at each
Each
and
vertebral
every
spine.
spinous process. Tip of the spinous process of each vertebra to decide the vertebral loop. That is how you
The
can.
posterior column means the posterior column sensations.
Posterior
Vibration
column is a
sensation.
part actually of sensory
Sensory
examination.
expression.
Don't take it separately. What I meant was pain and temperature, posterior column and motor. If you see of the three, posterior column would be most accurate,
Accurate.
most sensitive.
Just simply remember in the trunk and the legs, the sensory is more important in making in localizing, and in upper limb its reflex is making for localizing.
Because I have to tell you exactly, for reflex, suppose his biceps was absent.
Then you already showed the
Or
reflex.
triceps was absent. It would have been if biceps were present and triceps were absent, that would give you the level of lesion. That is the level of lesion. An absent reflex gives you a very good localization of level of lesion.
Upper limb reflexes, trunk and lower limb.
I have a question. Ma'am, after the history, what should be the diagnosis? Shall we call it quadriparesis or paraplegia?
Why should you not call quadriparesis?
When you
If
are
apparently you are saying that patient has weakness, he is talking about it, you should call it. What
Quadriparesis.
is wrong with calling it? It may be not
I
complete.
mean, but you
it
have to be
still
very sure that patient really couldn't move his arms
Couldn't
at
move,
all.
couldn't
But
have
if
a-
you, but that is will be fatal. If you say patient couldn't move his arms and legs at all after that episode, and power you show 5 by 5 around the
4 by
shoulder
5,
joint,
or
then
4
there
by
is
5.
something wrong between the history and examination.
They have to be very corroborative. Or unless it was 0 by 5 and then within 2 days it improved to 5 by 5, then that should come in your history. Then when he came, he was having complete loss of movement, but over 2 days movement recovered remarkably, so now he is able to walk or whatever.
course during hospitalization is
Very
always
vital.
an important component of any history, present history.
That is why I asked you, when did it
Always
start,
should
what happened
distinguish
to
between
it?
presenting complaints at the time of presentation and what is the course during hospitalization.
It is very important.
Now it's dense paraplegia in the lower limb and only the paraparesis in the upper limb.
No, not
Why we call him the quadriparesis?
Huh? Why not we call it? So what will you say then?
What upper and lower limbs are involved?
Involved is quadriparesis. Whether it is complete or it is incomplete.
For level,
There
you
is-
don't have to see the quantity of
there is
involvement.
We are not saying plegia, we are not saying quadriplegia, it's quadriparesis. Paresis means weakness, not complete loss. So you should say it's a
And at the
quadriparesis.
end of the history, you cannot be absolutely dogmatic about it being complete plegia and paresis. 99.9% will be right, but 0.1% like you in examination you might still find, despite the history, he says that my arms are not moving, but you can still see that he is able to lift and move little. So quadriparesis is not.
Quadriparesis
And
will be a
this
safer word
Will
rather
be safer
than
word, and this will
quadriplegia.
always come. And mind you that, as we told you in the beginning, this in an acute classical transverse myelitis, like we presume that this patient is at the moment, I also think I have not done full examination. this kind of a thing is only explained by extended
Chord
chord.
edema.
No other explanation.
Chord edema, venous engorgement and neuralgia.
Neuralgia.
Against ATM, sir, there is no history of
नहीं,
fever.
यहीं पे भी
No history.
Fully get-
Against ATM, sorry?
There is no history of fever.